Welcome to this video entitled, Prevention and Control of Nosocomial Pneumonia. Preventing pneumonia in the critically ill is a daunting task, and even controlling the incidence is difficult. Despite this challenge, many in the patient safety movement have suggested that nosocomial pneumonia should be a never event. While complete prevention of nosocomial pneumonia is unlikely, substantial progress has been made in reducing the incidence. Pneumonia is the most common nosocomial infection in the ICU. A large, one-day point prevalence study of pneumonia demonstrated that nearly 10% of ICU patients were being treated for pneumonia. Post-operative patients, especially those undergoing cardiothoracic, neurosurgical, and trauma-related surgery, appear to have the highest rates. Coronary care unit patients appear to have the lowest rates. Medical, respiratory, and other surgical patients demonstrate intermediate rates. The influence of endotracheal intubation is so dominant that nosocomial pneumonia in the ICU has been almost synonymous with ventilator-associated pneumonia, abbreviated as VAP. Endotracheal intubation increases the rate of nosocomial pneumonia between 3 and 21-fold. Research on hospital-acquired pneumonia, abbreviated as HAP, has been dominated by ventilator-associated pneumonia, and very little is known about pneumonia in non-intubated ICU patients. In addition, the role of both hospital-acquired pneumonia and healthcare-associated pneumonia, abbreviated as HCAP, pneumonia occurring in other healthcare settings, such as chronic ventilator facilities, inpatient rehabilitation units, and high-acuity nursing homes has been increasingly recognized. These ICU pneumonia cases are the cause of respiratory failure rather than a consequence of intubation as in ventilator-associated pneumonia, but with a frequency of multi-drug resistant, abbreviated as MDR, pathogens equivalent to that of ventilator-associated pneumonia. Lack of diagnostic accuracy severely compromises efforts to prevent nosocomial pneumonia. Etiologic diagnosis is difficult in patients who are not intubated. Radiographic interpretation is also problematic. NNIS proposed an alternative definition of infectious ventilator-associated complications, abbreviated as IVAC, that does not require a chest radiograph to meet the definition. Multiple subsequent studies have demonstrated that the infectious ventilator-associated complications definition is neither sensitive nor specific and question the ability of ventilator-associated pneumonia prevention strategies to alter the frequency of infectious ventilator-associated complications. Others ignore the need for abnormal chest radiographs and instead combine ventilator-associated pneumonia with a newly defined ventilator-associated tracheobronchitis, abbreviated as VAT. Whether ventilator-associated tracheobronchitis is an early stage of ventilator-associated pneumonia that progresses to ventilator-associated pneumonia is still debatable. A distinction should be made between prevention of all nosocomial pneumonia and prevention of life-threatening nosocomial pneumonia. The crude mortality rate for ventilator-associated pneumonia ranges from 24% to 76%, with an estimated attributable mortality of 20% to 30%. The highest crude and attributable mortality rates are associated with typical late-onset multi-drug-resistant microorganisms such as Pseudomonas aeruginosa, Acinetobacter species, and methicillin-resistant Staphylococcus aureus, abbreviated as MRSA. Unfortunately, the most effective and well-documented strategies to prevent pneumonia work predominantly or exclusively in early-onset ventilator-associated pneumonia and therefore have not resulted in a significant improvement in mortality. Conversely, One of the most consistent adverse effects of ventilator-associated pneumonia, including early onset, is a prolonged duration of mechanical ventilation. Because duration of ICU stay is the principal determinant of cost of care, prevention measures may be cost-effective even if they do not result in improved mortality. We will now discuss the pathogenesis. The key to prevention and control strategies is a clear understanding of the underlying pathogenesis of nosocomial pneumonia. The essence of nosocomial pneumonia pathogenesis involves three basic steps. 1. Colonization of the oropharynx with pathogenic microorganisms. 2. Aspiration of oropharyngeal contents into the lower respiratory tract. 3. Overwhelming of the host defense processes in the lower respiratory tract. Effective prevention and control measures can be analyzed by their effect on one or more of these steps. Despite the simplicity of this paradigm, assumption that the pathogenesis of all types of nosocomial pneumonia is the same would be naive and incorrect. An example is the role of gastric colonization preceding oropharyngeal colonization, the basis for attention to enteral feedings and stress ulcer prophylaxis in ventilator-associated pneumonia prevention. Although possibly important for pneumonia due to Enterobacteriaceae, gastric and enteric colonization has no role in the pathogenesis of Staphylococcus aureus or Pseudomonas aeruginosa pneumonia, the two most common causes of ventilator-associated pneumonia. Conversely, daily chlorhexidine baths did not prevent ventilator-associated pneumonia in a trauma population, but did significantly decrease ventilator-associated pneumonia from methicillin-resistant Staphylococcus aureus. Therefore, prevention strategies should be individualized to the patients, pathogens, and processes prevalent in a specific ICU. We will now discuss colonization with pathogenic microorganisms. The major antecedent event to most nosocomial pneumonias is colonization of the oropharynx with pathogenic bacteria. The oropharynx is not sterile, but the character of the normal flora is remarkably constant. A variety of factors alter the normal flora, allowing replacement by more pathogenic microorganisms. The importance of the normal flora is illustrated by the adverse effects of aseganin, an antimicrobial peptide active against almost all bacteria. Aseganin treatment not only failed to decrease ventilator-associated pneumonia rates, but was associated with a trend toward increased mortality. Time of exposure to these selective forces is critical. Early onset pneumonia, even early-onset ventilator-associated pneumonia, tends to be caused by less pathogenic microorganisms such as Streptococci, Haemophilus influenza, and methicillin-sensitive Staphylococcus aureus. Most selective forces are introduced in the hospital environment itself rather than specifically in the ICU. Therefore, patients who develop pneumonia during the first few days of ICU admission or mechanical ventilation are at risk for multi-drug resistant pathogens if preceded by a 3 to 5 day hospital stay. Many of the same factors also operate in skilled care nursing home facilities and have led to the designation of HCAP. Previously, colonization of the oropharynx by gram-negative enteric bacilli, generally from the Enterobacteriaceae family, was emphasized. As part of the normal bowel flora, oropharyngeal colonization occurs by one of two main routes. The first is reflux of bacteria into the stomach from the duodenum, with subsequent gastroesophageal reflux into the esophagus and oropharynx. Colonization and proliferation in the stomach are critical intermediate steps in this pathway. Therefore, many prevention strategies logically target the stomach. The other route is self-inoculation by the fecal-oral route, through contamination of equipment or the hands of healthcare providers or the patient. The colonization pattern differs among many hospital-acquired pneumonia or ventilator-associated pneumonia pathogens. Staphylococcus aureus, Pseudomonas aeruginosa, and Acinetobacter species are common causes of ventilator-associated pneumonia in many institutions. None of these microorganisms has a colonization pattern typical of Enterobacteriaceae. Staphylococcus aureus normally colonizes the skin and the nasopharynx. Colonization of the oropharynx from the nose, especially with the use of nasogastric tubes in critically ill patients, can occur quite easily. Similarly, Acinetobacter is found on moist body surfaces and in the gingival crevices of patients with poor oral hygiene. Pseudomonas aeruginosa is usually not part of normal bowel flora, but is ubiquitous in the environment. One of the unique aspects of Pseudomonas ventilator-associated pneumonia is the appearance of tracheal colonization before oropharyngeal colonization. Because colonization of the stomach is not an important intermediary step for these pathogens, the pneumonia they cause is unlikely to be affected by prevention measures directed at the stomach. Conversely, both methicillin-resistant Staphylococcus aureus and Acinetobacter colonization can be decreased with chlorhexidine whole-body bathing. We will now discuss avoidance of antibiotics. The single most important factor that leads to colonization of the oropharynx with pathogenic microorganisms is the use of systemic antibiotics, especially broad-spectrum. Antibiotic killing of the usual oropharyngeal flora gives pathogens a selection advantage. At the same time, some pathogens are also eliminated. For this reason, antibiotics function more as amplifying agents rather than as true causes of colonization. The pathogenic microorganisms must still reside in the area normally, such as nasopharyngeal carriage of Staphylococcus aureus, or be transferred from other sites, including the environment, to colonize. Thus, pneumonia can still occur despite avoidance of antibiotics. However, the causative microorganisms are more likely to be less virulent pathogens or even normal flora, such as alpha-hemolytic streptococci, and less likely to lead to life-threatening pneumonia. Diagnostic strategies for fever in the ICU that result in the use of fewer antibiotics have been associated with lower mortality. Shorter courses and fewer antibiotics for documented infections in critically ill patients have also been associated with a decreased risk of superinfection. Although avoiding antibiotics may have only a small effect on the risk of developing the first episode of pneumonia, limiting their use has a major effect on secondary pneumonia and infection-related death in the ICU. And now we will discuss topical antibacterial agents. In contrast to systemic antibiotics, the use of topical antibiotics for the prevention of colonization may be beneficial. In general, strategies rely on controlling pathogenic microorganisms at specific sites, despite the effect on normal flora. Topical agents generally do not have the toxicity of systemic agents, and although the use of topical antibiotics can lead to multi-drug resistant isolates, the risk may not be as great as with systemic antibiotics. We will now discuss selective digestive tract decontamination, abbreviated as SDD. Selective digestive tract decontamination is by far the most extensively studied and most aggressive topical antibiotic strategy to prevent colonization. Although the specific agents used in different studies vary, the major focus is on controlling oropharyngeal colonization by almost sterilizing the entire gastrointestinal tract, including the large bowel. Selective digestive tract decontamination is discussed more extensively in Chapter 119. In summary, despite more than 40 randomized, controlled trials, the benefit of selective digestive tract decontamination remains unclear. We will now discuss topical oropharyngeal agents. Controlling colonization of the oropharynx alone has also generated interest, since little disruption of the normal bowel flora is expected by treating only the primary area of concern. Oropharyngeal decontamination alone appears to be equivalent to selective digestive tract decontamination for prevention of ventilator-associated pneumonia. Chlorhexidine oral rinse has been the most extensively studied. Unfortunately, different concentrations of chlorhexidine have been used, and different populations have been compared. The strongest support for efficacy is for the 2% concentration. Chlorhexidine may not prevent infection with multi-drug-resistant pathogens such as Pseudomonas and Acinetobacter. Oral decontamination with other agents, such as povidone, iodine and antimicrobial peptides, has not demonstrated benefit. Recently, interest in universal decolonization of patients with daily chlorhexidine for 5 days and nasopharyngeal mepiosin demonstrated lower bacteremia rates with methicillin-resistant Staphylococcus aureus and all pathogens. No significant impact on methicillin-resistant Staphylococcus aureus pneumonia was demonstrated. We will now discuss aerosolized antibiotics. The earliest studied form of topical colonization prevention was aerosolized antibiotics. In the early era of mechanical ventilation, daily aerosolized polymyxine B resulted in a dramatic decrease in the rate of gram-negative ventilator-associated pneumonia. Not surprisingly, routine use was soon complicated by the emergence of antibiotic-resistant microorganisms. This feature, combined with a lack of mortality benefit, led to abandonment of this strategy. In a recent study, aerosolized ceftazidime did not decrease ventilator-associated pneumonia rates in trauma patients, but also did not increase multi-drug-resistant pathogen colonization. A recent variation of this practice is to use aerosolized antibiotics for purulent tracheobronchitis, thought to be a precursor to ventilator-associated pneumonia. We will now discuss avoidance of increased gastric pH. The normally acidic environment of the gastric lumen is extremely effective in preventing colonization with either swallowed oropharyngeal flora or refluxed enteric flora. Several prevention strategies focus on this aspect of prevention. We will now discuss stress ulcer prophylaxis. Because gastrointestinal bleeding from stress ulceration was at one time a substantial problem in ventilated patients and a major cause of death, prophylaxis against stress ulceration was considered critical for ventilated patients. However, the incidence of stress mucosal ulceration has decreased markedly as a result of better hemodynamic resuscitation, improved ventilatory strategies, and earlier use of enteral nutrition. The debate regarding the optimal gastrointestinal bleeding prophylaxis has therefore evolved over the past few decades. Initially, antacids were found to be inferior to histamine type 2 blockers, abbreviated as H2 blockers. In addition to increasing gastric pH, antacids increase gastric volume, which is probably an independent risk factor for ventilator-associated pneumonia. Subsequently, sucralfate was hypothesized to be superior to histamine type 2 blockers because it does not affect gastric pH and might have intrinsic antibacterial properties. No clear-cut benefit of sucralfate over histamine type 2 blockers in reducing ventilator-associated pneumonia has been found, while a slight but consistent increase in gastrointestinal bleeding has been documented. Proton pump inhibitors, abbreviated as PPIs, appear equivalent to histamine type 2 blockers. A more important issue is whether stress ulcer prophylaxis is needed at all in most mechanically ventilated patients. The few placebo-controlled trials suggest that histamine type 2 blockers and sucralfate may lead to an increased risk of ventilator-associated pneumonia compared with controls. Several multivariate analyses found pump inhibitors associated with increased pneumonia rates, including hospital-acquired pneumonia or ventilator-associated pneumonia, healthcare-associated pneumonia, and even community-acquired pneumonia. A subgroup of patients at increased risk for gastrointestinal hemorrhage can be identified, and patients without these high-risk factors may not need prophylaxis. And now we will discuss enteral nutrition strategies. Malnutrition is clearly associated with an increased risk of pneumonia and increased mortality in the critically ill. In addition to classic effects on cell-mediated immunity, an effect specific to pneumonia is increased binding of gram-negative bacilli, including Pseudomonas, to epithelial cells. Enteral administration of nutrition is the preferred route for treating and preventing malnutrition in the critically ill, although parenteral nutrition in high-risk patients is preferable to no nutrition. Meta-analysis has suggested that patients can even be fed soon after gastrointestinal surgery. However, continuous enteral nutrition infusions may increase both gastric pH and gastric volume, increasing ventilator-associated pneumonia risk. A randomized trial found that the risk of ventilator-associated pneumonia was increased with early aggressive feedings compared with low-level enteral nutrition, approximately 20% of goal feeding rate. The lower rate was chosen to avoid atrophy of the microvilli of the enteric mucosa, a potential source of nosocomial infection. The increased risk of ventilator-associated pneumonia was attributed to an increased risk of aspiration, which is also seen in surgical series. However, meta-analysis of early versus delayed enteral nutrition suggests a mortality benefit and probable decreased risk of ventilator-associated pneumonia with early feedings. A balance between potential risks would be early initiation of enteral feeding but avoidance of aggressive infusions that might cause high gastric residuals and gastric distension. Neither bolus feedings nor acidification of enteral feedings improved ventilator-associated pneumonia rates but were associated with increased adverse events. We will now discuss modified endotracheal tubes. Bacteria can adhere to the polyvinyl chloride surface of endotracheal tubes through secretion of a glycocalyx. Protected from systemic antibiotics and host defense processes, microorganisms in this glycocalyx can become a source of re-inoculation of the lower respiratory tract. This mechanism may explain the high rates of recurrent ventilator-associated pneumonia, particularly for Pseudomonas. A silver-impregnated endotracheal tube demonstrated a lower incidence of ventilator-associated pneumonia and a delay in onset in those who do develop ventilator-associated pneumonia, although cost remains a barrier to routine use. We will now discuss cross-infection. The role of cross-contamination in the ICU should never be underestimated. Cross-contamination can cause colonization with specific pathogenic bacteria in a patient who has no other risk factors for that microorganism. In particular, Pseudomonas aeruginosa and methicillin-resistant Staphylococcus aureus appear to have the greatest potential to cause cross-contamination and subsequent infection. By far the most important factor in cross-infection is hand washing among caregivers. Multiple studies document poor infection control practices of medical personnel, including physicians and bedside nurses. The risk of inadequate hand washing increases with the intensity of care needed for an individual patient and with the number of patients per nurse. Use of an alcohol-based, self-drying hand wash appears to be effective and to increase compliance with hand washing. Routine decolonizing also appears to decrease rates of cross-infection. Avoiding cross-contamination via medical equipment is also important. Contaminated equipment remains a major cause of epidemic outbreaks of nosocomial pneumonia. Any clustering of ventilator-associated pneumonia, especially when caused by an unusual agent, should raise this possibility. Respiratory therapy equipment is particularly suspect, and adherence to standards for the sterilization of ventilators, bronchoscopes, and other reusable equipment should be rigorous. Probably the best prevention strategy is a continuous, multifaceted, multidisciplinary program of infection control. An important component of this program is monitoring ventilator-associated pneumonia rates and providing feedback to individual units on their infection rates. Although such a program is costly to develop, the substantial cost-benefit of avoiding pneumonia usually justifies the expense. We will now discuss aspiration. The role of aspiration in nosocomial pneumonia is probably the least controversial. Evidence from a variety of sources documents the importance of aspiration, although the definition varies. We will now discuss large volume aspiration. Large volume aspiration is clearly a risk factor in non-intubated ICU patients. Predisposing factors for this type of aspiration are gastrointestinal, such as protracted vomiting from bowel obstruction or gastrointestinal bleeding, and neurologic, including seizures, induction of anesthesia, and alcohol intoxication. Appropriate use of endotracheal intubation is actually a protective factor for this type of aspiration. If large volume aspiration has occurred, selective use of bronchoscopy to extract solid material that might occlude a bronchus and cause post-obstructive pneumonia may be of benefit. Empirical antibiotics, especially prolonged courses, do not clearly prevent pneumonia, but do select for more virulent microorganisms. We will now discuss small volume aspiration. Aspiration of a smaller volume of secretions is also associated with pneumonia in both intubated and non-intubated patients. Neurologic disease with an inability to protect the upper airway is consistently documented as a risk factor for pneumonia. In this situation, aspiration occurs before or in conjunction with endotracheal intubation. A large inoculum of oropharyngeal flora reaches the lower respiratory tract, and clinical pneumonia usually occurs within 48 to 72 hours. High levels of amylase in BAL fluid is a marker of this risk. Prevention of pneumonia from small volume aspiration is probably best achieved by prophylactic antibiotics. Prospective observational studies suggest that antibiotics early in the course of mechanical ventilation are associated with a lower incidence of pneumonia. However, the best evidence is a prospective, randomized trial of short-course cephalosporin prophylaxis, 2 doses, in patients intubated for non-traumatic coma. The incidence of ventilator-associated pneumonia was only 23% in the prophylaxis group, compared with 66% in the control group. These findings are corroborated by a before-after quality improvement study and by the many selective digestive decontamination studies reporting a decreased incidence of pneumonia when a short course of systemic antibiotics was included with the topical antibiotics. Prophylactic antibiotics are effective only in the initial intubation of patients not previously hospitalized for a significant period and is dependent on the aspirated bolus containing mainly normal oral flora rather than multi-drug resistant pathogens. This prevention strategy seems to contradict the importance of avoiding unnecessary antibiotics discussed earlier. Two aspects outweigh the potential downside of increased risk of oropharyngeal colonization with more pathogenic bacteria. First, antibiotics are continued for only 24 hours. Second, the 40% lower risk of pneumonia in patients given prophylaxis avoids a subsequent longer course of antibiotics, often with a wider spectrum. We will now focus on microaspiration. Microaspiration is by far the most important form of aspiration in intubated patients. Oropharyngeal secretions pool above the cuff of the endotracheal tube in most intubated patients. Extremely small volumes of secretions can pass below the cuff during small movements of the endotracheal tube associated with head repositioning, coughing, and other activities. Up to 45% of patients have abundant aspiration in the first 48 hours post-intubation. Because oropharyngeal secretions contain 10⁶ to 10⁻10 bacteria per milliliter, even secretions of 0.1 milliliter can present a significant infectious challenge to the host defenses of the lower respiratory tract. We will now discuss shorter duration of endotracheal intubation. The risk of ventilator-associated pneumonia is not linear. The greatest risk occurs early, with subsequent tapering in frequency with each week. In addition, early-onset ventilator-associated pneumonia, within 5 to 7 days of intubation, has the lowest attributable mortality. Therefore, the sooner the patient is extubated, the lower the cumulative risk of pneumonia and the lower the risk of lethal nosocomial pneumonia. The best strategy is avoiding intubation completely. Management of many patients with non-invasive ventilation, abbreviated as NIV, is now standard practice in most ICUs. However, patients who fail non-invasive ventilation appear to have an increased duration of subsequent endotracheal intubation and thus an increased risk of ventilator-associated pneumonia. Careful selection of candidates for non-invasive ventilation and early abandonment in unsuccessful cases are critical to decreasing the pneumonia risk. Even when patients are intubated, variations in duration of mechanical ventilation for the same type and severity of critical illness suggest that efforts to shorten the duration are a viable approach to prevent ventilator-associated pneumonia. Several protocolized strategies demonstrate significant benefits, including daily interruption of sedation and assessment of ability to wean. The downside of an aggressive extubation strategy is the association between reintubation and a threefold increase in risk of ventilator-associated pneumonia. Reintubation re-exposes the patient to the risk of small volume aspiration. In addition, colonization of the oropharyngeal secretions by more pathogenic bacteria is more likely because of the prior episode of intubation, and short-course antibiotics will not have the same beneficial effect. Therefore, although avoiding or shortening the duration of mechanical ventilation is clearly a laudable goal, an increase in the risk of ventilator-associated pneumonia may occur with an overly aggressive approach. We will now discuss the avoidance of ventilator tubing manipulation. Condensation of exhaled gas in the expiratory limb of the tubing or from humidifiers in the inspiratory limb can become heavily colonized with bacteria. Installation of this liquid bolus into the patient's airway during manipulation of the tubing or movement of the patient can present a significant bacterial challenge to lower respiratory tract defense. The most consistent evidence that ventilator tube manipulation increases the risk of ventilator-associated pneumonia is that increasing the interval between ventilator tubing changes decreases the incidence of ventilator-associated pneumonia. Most institutions no longer change ventilator tubing unless gross contamination is present. Meta-analysis of 8 randomized controlled trials of heat and moisture exchangers, abbreviated as HMEs, rather than heater humidifiers, suggested a 30% reduction in ventilator-associated pneumonia rates, especially if the patient was ventilated for more than 7 days. Increased rates of endotracheal tube occlusions secondary to inspissated secretions with the use of heat and moisture exchangers and other considerations, especially cost, determine the frequency of their use. Transporting ventilated patients outside the ICU, usually for diagnostic procedures, is also associated with an increased risk of ventilator-associated pneumonia. In a prospective study, 24% of patients requiring transport outside of the ICU developed ventilator-associated pneumonia, compared with only 4% of patients who did not. More than half of ventilated patients required transport at least once. Need for ambu bagging, changing ventilators, moving the patient out of bed, and other aspects of the process all increase the possibility of inadvertent introduction of ventilator tubing condensate into the patient. In addition, unintentional extubation is greater when transferring ventilated patients. We will now discuss the maintenance of artificial airway cuff pressure. Adequate pressure, generally greater than 25 centimeters of water to maintain a seal around the cuff of artificial airways, is critical to prevent microaspiration. Maintaining continuous control of tracheal cuff pressure resulted in a decrease in ventilator-associated pneumonia incidence from 22 to 9.7 confirmed cases per 1,000 ventilator days. Maintenance of cuff pressures may also decrease proximal airway secretions, the hallmark for the diagnosis of ventilator-associated tracheobronchitis. The addition of low levels of positive end expiratory pressure, abbreviated as PEEP, has been associated with decreased aspiration and risk of ventilator-associated pneumonia, possibly due to the greater attention to tracheal cuff pressures required in patients on positive end expiratory pressure. Inattention to tracheal cuff pressure obviates the benefit of other interventions, such as continuous aspiration of subglottic secretions, abbreviated as CAS. We will now progress to modified endotracheal tubes. A variety of modifications of the endotracheal tube itself have been designed to decrease microaspiration. Most attempt to minimize longitudinal folds in standard tracheal tube cuffs by changing the type of material or the shape of the cuff. No significant difference in ventilator-associated pneumonia rates has been found in tapered versus cylindrical or polyurethane versus polyvinyl chloride cuffs. An endotracheal tube that allows continuous aspiration of subglottic secretions, abbreviated as CASS, pulled above the endotracheal tube cuff has been extensively studied. The extra channel with a lumen on the dorsal surface, just above the level of the inflatable cuff, allows aspiration of secretions pulled above the cuff. One clinical practice guideline found the greatest level of evidence for ventilator-associated pneumonia prevention was continuous aspiration of subglottic secretions. Studies of continuous aspiration of subglottic secretions have variably demonstrated lower ventilator-associated pneumonia rates, but mainly in early-onset ventilator-associated pneumonia. No decrease in ventilator-associated pneumonia due to multi-drug-resistant microorganisms and no mortality differences have been demonstrated. The benefit of continuous aspiration of subglottic secretions is obviated if the patient receives antibiotics early in the course of mechanical ventilation, and pneumonia can also occur if the system malfunctions, usually caused by plugging of the lumen or low cuff pressures, allowing secretions to drain into the distal trachea rather than collecting above the cuff. These factors and the high cost have limited the use of this modality. We will now discuss early tracheostomy. Tracheostomy has potential benefits for ventilator-associated pneumonia prevention. The glottis is not held open by the endotracheal tube and the vocal cords can be opposed, decreasing the risk of aspiration significantly. The security of a tracheostomy may allow greater mobilization and a greater amount of time spent in the upright position, also decreasing aspiration. Routine tracheostomy may be one explanation for the leveling off of ventilator-associated pneumonia incidence after several weeks of mechanical ventilation. The benefit of early tracheostomy remains unsettled. Technique may also matter, with tracheostomy performed by the percutaneous dilatational technique more beneficial. And now we will look at semi-recumbent positioning. The degree of gastroesophageal reflux is significantly greater in supine patients than in semi-recumbent patients. Not only is reflux greater, but bowel flora were found to colonize the oropharynx and bronchial tree in 68% of patients ventilated in the supine position, compared with only 32% in the semi-recumbent position. A prospective, randomized trial clearly demonstrated that both clinically suspected and microbiologically confirmed cases of ventilator-associated pneumonia were more common in patients ventilated in the supine position, that is 8% of clinically suspected ventilator-associated pneumonias versus 34% for semi-recumbent. Supine body position, odds ratio 6.8, and enteral nutrition, odds ratio 5.7, were both independent risk factors for ventilator-associated pneumonia, with the highest frequency in patients receiving enteral nutrition in the supine position, that is 50%. Avoiding the supine position as much as possible is a simple and effective preventive measure that should be practiced in all ICUs. However, compliance with elevation of the head of the bed to 45 degrees is difficult, and smaller degrees of elevation are not associated with decreased ventilator-associated pneumonia rates. In patients unable to be placed in the semi-recumbent position, continuous lateral rotation with specialized beds may be beneficial. We will discuss avoidance of gastric overdistension. Even in a semi-recumbent position, many patients still have gastroesophageal reflux and micro-aspiration when given enteral feedings. The major issue of overdistension of the stomach can be addressed several ways. The first is use of nasoenteric tubes rather than nasogastric tubes. Although attractive theoretically, meta-analysis of 11 randomized, controlled trials did not show a ventilator-associated pneumonia prevention benefit of post-pyloric feeding compared with gastric feeding. The major limitation is the difficulty placing post-pyloric tubes. A second strategy is the use of gastric prokinetic agents such as metoclopramide. An additional benefit of these agents is increased tone of the lower esophageal sphincter, which potentially decreases the risk of reflux while increasing gastric emptying. Once again, a randomized, controlled trial failed to confirm the benefit of using this agent to decrease the risk of ventilator-associated pneumonia. We will now focus on overwhelming lower respiratory host defenses. An underappreciated fact regarding nosocomial pneumonia is that despite the extremely common occurrence of aspiration of oropharyngeal secretions containing pathogenic bacteria, only a minority of colonized patients actually develop pneumonia. In the classic study by Johansson and colleagues, only 23% of patients with gram-negative colonization of the oropharynx subsequently developed pneumonia. Others have shown that quantitative culture levels of microorganisms equivalent to those found in pneumonia can transiently appear in routine non-bronchoscopic BAL samples without causing clinical ventilator-associated pneumonia. Thus, the two steps described earlier, colonization by pathogens and aspiration, are necessary, but not sufficient causes of nosocomial pneumonia. The third step in the pathogenesis of nosocomial pneumonia, overwhelming the lower respiratory tract defenses, is the least studied or understood. A major reason for this lack of understanding may be that the causes are heterogeneous and patient-dependent, in contrast to the stereotypical steps of colonization and aspiration. As infection control and patient safety efforts become more effective, the remaining patients who develop ventilator-associated pneumonia are even more likely to have significant defects in lower respiratory tract host defense. Patients who develop ventilator-associated pneumonia should generally be considered to have a form of acquired immunosuppression. The more frequent occurrence of other nosocomial infections in patients with ventilator-associated pneumonia supports this concept. In addition, some ventilator-associated pneumonia patients develop multiple separate episodes of ventilator-associated pneumonia, suggesting disproportionate compromise of lower respiratory tract defenses. Many of the causes of compromised lower respiratory tract defenses involve underlying disease or critical illness, precipitating ICU admission and the need for mechanical ventilation. However, several risks generic to most ICU patients may be targets for prevention. And now we will discuss minimizing antibiotic use. Rather than being sterile, lung alveoli harbor a normal bacterial flora. This recognition raises important issues in understanding the development of hospital-acquired pneumonia or ventilator-associated pneumonia. The normal lung microbiome is similar to that of the normal oropharynx, predominantly streptococci but also anaerobes, Haemophilus, and mycoplasma, but at significantly lower concentrations. This normal alveolar flora therefore represents an important component of host defense that, similar to that of the oropharynx and the gastrointestinal tract, is adversely affected by systemic antibiotics. Pseudomonas pneumonia is virtually never seen without previous antibiotic exposure and develops with progressive monolithic replacement of the normal heterogeneous lung microbiome in response to antibiotic pressure. Minimizing the effect of antibiotics on ventilator-associated pneumonia may occur with enteral probiotics, but lung-specific therapy is not available. Diagnostic strategies for ventilator-associated pneumonia that result in less antibiotic treatment and earlier discontinuation in culture-negative patients have consistently resulted in improved mortality and less superinfection. We will now discuss corticosteroids. Systemic corticosteroids have well-documented anti-inflammatory effects that can influence immune function. The difficulty in determining the effect of corticosteroids on risk of ventilator-associated pneumonia is the competing beneficial effect on other risk factors for ventilator-associated pneumonia. An example is that the use of corticosteroids may allow earlier extubation of a patient intubated for an exacerbation of asthma, thereby lowering the risk of ventilator-associated pneumonia. This dual effect probably holds true for most cases in which corticosteroids are used acutely for critically ill patients. The potential benefits begin to be outweighed by adverse consequences after more prolonged courses. We will now discuss transfusions. A common cause of immunosuppression is red blood cell transfusions. This effect of transfusions has been known for decades and was used therapeutically in the past for pre-transplantation management of patients with end-stage renal disease. The transfusion trigger varies widely among institutions and even among individual practitioners. A conservative transfusion policy was reported to be associated with equivalent mortality to more liberal transfusions in most ICU patients and decreased ventilator-associated pneumonia rates in trauma patients. Finally, we will now discuss a few key points. 1. A distinction should be made between the prevention of all nosocomial pneumonia and the prevention of life-threatening nosocomial pneumonia, usually late-onset ventilator-associated pneumonia. 2. Pathogenesis of nosocomial pneumonia can be broken down into 3 basic steps: colonization of the oropharynx with pathogenic microorganisms, aspiration, and overwhelming of the lower respiratory tract's host defense processes. 3. The most important factor in colonization of the oropharynx with pathogenic microorganisms and compromise of distal lung defenses is the suppression of normal flora at these sites by systemic antibiotics, especially broad-spectrum antibiotics. 4. The risk of ventilator-associated pneumonia is time-dependent, so any maneuver that decreases the duration of mechanical ventilation will decrease pneumonia rates. 5. Avoiding the supine position as much as possible in ventilated patients and maintaining adequate tracheal cuff pressure are simple and effective measures to prevent micro-aspiration and should be practiced in all ICUs. 6. Several lines of evidence suggest that minimizing the number of manipulations of the ventilator tubing will decrease the incidence of ventilator-associated pneumonia. 7. Causes of the relative immunocompromise that allows bacteria to overwhelm local host defenses in the lung are heterogeneous and patient-dependent, unlike the stereotypical steps of colonization and aspiration. Thank you.